I'm just gonna kind of get the pictures off the side so I can see. Now, can everybody hear me fine?
Yeah.
Yes. Awesome. Okay, so thanks for asking me to speak tonight. So I was asked probably about a month and a half ago by Lori to do the talk, and I do quite a bit of talking on the topic of pelvic floor, and you'll see in some of my slides I've done at different venues. So um, although I would say that the majority of my clients right now are definitely female. I definitely treat prostate clients as well. So, and a pelvic floor is a pelvic floor. You'll see as we do the presentation, there's some variations, but honestly, it's quite similar male to female. And it's really just those of us who treat this area and what we're trying to do and achieve and help patients with. So a little bit about myself. I did graduate in 1993, so that's quite a little while ago. So going on 31 years. I took my first pelvic floor course in 2008. So it's about 16 years. So about half of that time I've been doing pelvic floor. I currently work out of an obstetrician gynecology office, maternity and wellness in Regina. So I just have a one room there. I treat my clients there. I treat males, females, young, old, doesn't matter. If you have a pelvic floor, I will treat you. And I also have worked with the multidisciplinary chronic pelvic pain team since 2001 with the SHA. When I'm not doing that and treating patients full time, I actually have a non-physician teaching position with the College of Medicine. So starting a couple of years ago, I now teach every third year med student that goes through their obs and gynae clerkship, spends half a day with me in the clinic. And then I actually go and I teach them at the sim lab at the hospital on how to assess the pelvic floor. Physicians currently, or up to this point, have not been taught how to assess the pelvic floor musculature. And so we're one of the first programs in Canada, and they're hoping to start this in Saskatchewan earlier or later this year. And when I'm not doing that, I'm speaking at conferences and teaching workshops at various obstetrician gynecology conferences across Canada. So questions and kind of curiosities that you may have. And what we're going to talk about tonight is what actually is the pelvic floor and what are its functions. Nothing too complex, and most of you know this already just because you've kind of had to figure it out. But just adding a little more clarity to that. I'm going to talk a little about who can actually treat pelvic floor. So why do not all of us treat pelvic floor as physios, and kind of hoops do we have to go through so that we can actually treat pelvic floor clients. A little bit about the benefits of doing pelvic floor physio, and I've heard a lot of you already, speak to that point just in the introductions. That's really good to hear that you're already kind of, number one, knowing the possible benefits, and even better, those of you who are experiencing benefits from it. And then how to access pelvic floor physio services. So how do you figure out which physios can do this, which ones can't, who treat men, who treat women, and just navigating through that a bit. And then what to expect when you come for a pelvic floor assessment. And a few of you have already done that as well, and you've spoken about that a bit as well so far tonight. So a little bit more, what is the pelvic floor? So just to clarify, there's quite a bit that is involved in the pelvic floor. So it's the bones, it's the muscles, it's the connective tissue, and together, all of that put together, and how it provides support for the pelvic floor and the pelvic organs and the spine and the pelvic girdle, all so that assists with the functions that have to occur in that area, such as urinary, defecatory, and sexual function. Further to that, oh, my computer's doing a little funny thing. Sorry, guys. There we go. And in particular, these functions require relaxation and coordination of the pelvic floor muscles. This isn't always purely just about strength. You also need coordination of those muscles working together and everybody doing what they need to do at the right time so that these functions can be maintained. And so hence when you have either impairment of relaxation or that ability to have that coordinated muscle contraction, that can result in various symptoms like difficulty urinating, difficulty having bowel movements, pelvic pain, and sexual dysfunction. So who has a pelvic floor? Well, everyone. And the reason I say this is because I do predominantly treat females, the amount of times that I get asked by women if men actually have a pelvic floor, I would be a rich woman for if I had a buck for every time someone asked me that. I find it quite comical, but I mean, I just know the anatomy. But the thought that women think that men don't have a pelvic floor is just demonstrates the level of that so many people don't know our anatomy and we do not talk about this enough. So yes, men have muscles, men have connective tissue, men have ligaments, men have organs, and men have bones in their pelvic region, just like women do. And so if we take a look at the bones, we talked about that in an earlier slide, the pelvic floor does involve all of these areas as well. So our lumbar spine, our hips, our pelvic girdle, our sacrum, our tailbone. That's important because for some people, sometimes why they can be having some difficulty after a surgical procedure or a treatment or after just having a condition, you can sometimes end up with problems in these joints, which also affect your ability to control the muscles that are attached to these bones. And a lot of people don't think about that. And so we'll talk about this later in the slides, but sometimes we think it has everything to do with weakness. And sometimes these joints are very stiff. And if the joints are stiff, the pelvic floor muscles that attach to them will also be very tense. And then they don't work properly because they're too tense and they're not able to turn on and off. So it's really important that we look at the joints in the area because if those are involved, in order for us to optimize function in the muscles, we want to make sure that these are addressed as well. So if we look a little bit at the anatomy of the pelvic floor of a male, we have, this would be demonstrating the more superficial anatomy. And so these are muscles that we can actually palpate externally. So without doing a digital rectal exam, just on the outside and palpating along the bones and in that area between the testicles or the scrotum and the anus, we can palpate these muscles. And so we can get to those externally. And then internally, we have all of these muscles, the ones that are going around the rectum and then coming out and attaching to the pelvis. And then the other part that we talked about in the earlier slide about what makes up the pelvic floor is not just the bones, not just the muscles, but we also have ligaments and connective tissue that are holding the organs in place. And you can see in that one diagram on the left-hand side, there's a bunch of arrows going there. We have a kind of triangular, kind of clear organ there that would be representing the bladder, and then the kind of bluer prostate in the just below it. And then you have, they're just representing that we have ligaments going out from those areas that attach those organs to the pelvis. And that's what keeps things in place. Otherwise, they would be prolapsing and falling out of our bottom. So we want to have those ligaments in place. This is just a little drawing that I did myself just to kind of show how, you know, you have your sacrum or your tailbone, that kind of solid backbone at the back. And in the front, we have our pubic bones. And in between, in that pelvis, you have your bladder. And then right below it, you've got your sphincters, your internal urinary sphincter, your prostate, and then the external sphincter, and then that urethra carrying the urine out. All those yellow arrows that you see is where you have connective tissue and ligaments going from those organs and then attaching them to the pelvis around so that everything is held nicely in place. Here's another picture that I found that, you know, is a little bit probably easier to see. You know, on the left-hand side, you can see the bladder at the top. There's those two kind of little pieces on the sides that would be, it's not just on the sides, it would go around that urethra, and that would be your internal urethral sphincter that is in that area between the bladder and the prostate. Then below the prostate, and you can see this on the other picture as well, kind of more in that reddy brown color, your external urethral sphincter. So you have two. That internal one that is between the bladder and the prostate is not under your voluntary control, meaning you do not control that one. And typically, when an individual is at rest, that sphincter is a muscle that has a bit of a contraction to press or hold on your urethra to keep urine from coming out. So we don't always have to think about squeezing to hold in urine. Our bladder is always filling up with urine, and we don't always feel like we need to pee, because as that urine fills the bladder, our body senses the stretch in the bladder, and it tells that internal sphincter to contract a bit just to hold the urine in. When it is convenient, typically for us to urinate, when we get close to a bathroom, when we stand and we get ready to urinate, that muscle knows that it can let go. The external sphincter, we are 100% under conscious control, or that one is. It will automatically have a bit of tone in it throughout the day to keep the sphincter or keep the urethra closed. But when we know we have to go to the bathroom, we can feel that our bladder, we feel that urgency, and we know our bladder is getting full. We think about that one, and that's the one that we try to squeeze so that we can get ourselves to the bathroom while maintaining our continence. During prostatectomies, during those surgeries, during radiation, often the internal sphincter is often removed with the prostate surgery. So you lose your very first sphincter, or at a minimum, it is often compromised. And so we are now relying almost solely on that lower sphincter that we have active control to try to keep us continent. And that's the one, when we do the strengthening exercises, that we are hoping to strengthen up. So who can provide pelvic floor physio, and who does this? So pelvic floor physical therapy is actually a specialty area within physical therapy training that focuses on rehab of those muscles and that connective tissue of the pelvic floor, as well as the adjacent bones and joints. And for the reasons that I've already mentioned, why all of that is important if we're going to optimize function of the pelvic floor. It can be used to address issues such as muscle weakness, tightness, or coordination and tissue flexibility, as well as urinary, defecatory, and sexual functions. And although pelvic floor physical therapy is often associated with women's health, we know that everyone has a pelvic floor, and pelvic floor function may be altered in males as well. This may occur due to an injury. It's not just males with prostate issues. You could have an injury, you can have a medical condition or a disease, you can have surgery, you can have medical conditions or medical treatments, and even psychological or psychosocial factors can affect your function of those muscles as well. The best example would be is that when we're really nervous or we're stressed, we tend to tighten up not only in our neck and shoulders, but often in our pelvic girdle. And so causes of, and I apologize, guys, sometimes I'm saying my titles wrong because I have a thing going right across the top of my screen for the Zoom. Oh, there, it just moved. Good. But I haven't been able to see all my stuff, but I can see now. So causes of post-operative urinary incontinence. So what can cause this? Well, due to extensive dissection, so when they go to remove that prostate and they're trying to do it as meticulously as they can, sometimes during that dissection and during the surgery, injuries can occur. Two, and we had mentioned already, oh, here's what happened. When I switch that one, then I can't change another. There we go. To the internal sphincter, And that internal sphincter, as we mentioned before, is that one that's sitting right below or right beneath the bladder and kind of almost right on top of the prostate. And so often it either gets removed, and at minimum, it's often damaged. And that as the removal of the proximal urethral sphincter and pubourethral suspensory ligaments. So again, that's where some of those ligaments are altered too in the surgical process. And then you can have sometimes damage to the external urethral sphincter. More often than not, that's due to when you have, if the nerve is damaged a little bit. So this sphincter is the only one that's often remaining and now becomes your main structure responsible for urinary continence. You can also have some damage or injuries to the supporting structures of your urethra, which is the tube that carries the urine from the bladder to the outside. And the neurovascular bundle, which is actually just a really fancy name for a bundle of nerves and blood vessels that are around that prostate. And sometimes damage to these nerves and blood vessels may affect the function then of that external urethral sphincter, because that's the one that we need to be able to use to hold that urine in when we're feeling urgent. But if the nerve supply or the blood supply has been altered going to it, then sometimes it doesn't work as well. And then possible formation of post-operative fibrosis. That is not unique to prostate surgeries. Anytime, anywhere in the body where we have an injury or to soft tissue or bone, as it heals, it can fibrose, which just means that it toughens up and thickens up and gets stronger. But sometimes it can get a little too thick, a little too tight, and a little too immobile, and then it sometimes doesn't work as well. And so going back then to that anatomy where we've got your internal sphincter, which we just talked about, can get altered, and then the prostate gland, and then that external sphincter at the bottom, the one that's got the B going through it, that's the really important one that we're trying to liven up or get it working again. And so who can perform pelvic floor physiotherapy? Because it's not everybody. So different provinces actually have different regulations, but typically only non-invasive techniques, meaning no digital exams. So all physios, when we go through training, learn a little bit about the pelvic floor, but you can only treat externally if you do not take postgraduate courses. If you do, then the invasive, meaning the digital exams, the internal examination of the structures, and more knowledge on that can only be performed by physical therapists who have successfully completed the recognized education programs for their particular province in the area of urogenital and rectal dysfunction. And even pelvic floor physios do not all take the ones that are specific to males. And so there's a whole bunch of courses that you can take, and we can all choose what we take, which is why not all physios will treat and do male pelvic floor and sometimes only choose to do female, or you may have vice versa where they treat male but don't treat female. And so for a list of pelvic floor physios near you, for Saskatchewan at least, we have through the Saskatchewan Health Authority, if you just Googled that and said Saskatchewan Health Authority list of pelvic floor physical therapists, you will get a document that looks kind of like this at the top. This is kind of more almost, I tried to screenshot almost the first page. And so it's all divided into kind of regions of Saskatchewan. And you can see where the clinics are listed on the left-hand side. And then on the right-hand side, you can see their contact information and a checkbox for whether, number one, if there's a fee for service, meaning is this a private clinic and that it's a pay as you go, like you pay your physio fees for private physical therapy, and then whether or not they treat just women or whether they treat men and women, and whether or not they treat pediatrics, because also kids, that's another different kind of avenue or branch that we can take for treating. In most, yeah.
Suzanne, sorry to interrupt. This is Jeff. Just so you know, we have handouts for everybody for this list. So we have it
Perfect.
here on the table. And for those of you online, You can either look for it there or it's in our newsletter as well. You can click on the link in the newsletter and bring up that list. Thank you.
Perfect. Thank you very much. On the next page, which we're not going to go through all this, but I just wanted to show you guys. So at the Urology Center of Health at St. Paul's Hospital, they actually, so that's in Saskatchewan, they actually have a pre and post prostatectomy program, and it is men only. So it's just for men. And that one is no cost to the patient because that's publicly funded. But most, that would be the only one that I know of. There may be other, but that's the only one I know of in Saskatchewan.
You're correct, Suzanne.
Yeah. So it's unfortunate, but it is what it is. So they do have it there. There's a recent Castellan et al. They just did a study in 2023. And so I thought I'd pull this one up a little bit, and it was really speaks to kind of, so what do we do after prostatectomy, and what is research telling us, and what's kind of best practice? And they say in there that pelvic floor muscle exercises is the most common management to improve the strength of the pelvic floor and try to recover the sphincter weakness. And we've already talked about how important that is. Normally, they are prescribed post-operatively with verbal instructions, and unfortunately, that could lead to improperly performing the exercises, which as a clinical practitioner and seeing patients, I 100% agree with that. I find that people find it very difficult to know how to do these exercises. And especially if it is occurring post-op, when you have a deficit in the function of that muscle, it is extremely difficult on your own to figure out how to do these exercises, which is why they say best results occur when they're performed properly and for extended periods of time. And the recommendation is to have a therapist-led pelvic floor muscle training correlated with a faster recovery in patients with urinary incontinence after radical prostatectomy. So they knew, or when they did the study, they found that the men who were taught the exercises by a physio, then they performed them better, they knew how to do them better, and their post-op outcomes were better. On another slide, we go on to talk about how it's even better if you teach someone how to do these before their surgery, before the muscles are compromised. Learn them when everything is working properly, rather than teaching you once it's already dysfunctional. It's way easier to do something if you've already done it before there was the injury. So the recommendations then that also came out of another, this is an old study from 2006. And they said in that one that pre-operative training could improve the strength and the skill of the patients, reducing the time to continence, meaning it would take less time to recover that continence post-op when the exercises were taught pre-operatively. And I always say, and I've said it in the other slide, it's always easier to train a muscle for any surgery prior to surgery. Just like we do for people when they have knee surgeries, shoulder surgeries, hip surgeries, we love to treat them before rather than just training them after. And so is anybody curious about what to expect? Now, many of you have already been involved in pelvic floor physio, so you know, but any of you who haven't done this yet or are wondering what to expect, basically, the first thing is you will always get a full explanation on what to expect. We are not doing this quickly, and it is always with informed consent. There's lots of opportunity to ask questions and discuss prior. We're taking a full history that at a minimum is taking half an hour, sometimes as long as 45 minutes to an hour before we even put our hands on the patient. We have ongoing consent is required throughout the whole entire process. At any time, if you're getting uncomfortable, you just say, and we can defer to the next, or we can try something different. We just use a regular physio table. There's not stirrups or something like you think like an obstetrician gynecology exam for females in the office. It's just a regular physio table. Often males are laying on their back in crook lying with their knees bent. Some physios prefer to treat males on their side and doing the digital exam that way. and appropriate draping, meaning we'll cover you with a sheet. There's sheet on below and a sheet on top. So no one's, just exposed. And often we'll give a patient a handheld mirror if they want to watch and see what we're doing so that they can understand it a bit more. Sometimes when it even just helps with figuring out what muscles to use, we're often giving you a diagram like those pictures that I showed before of the muscles so you can follow along as we assess each one and tell you which ones are working good, which ones maybe are a little bit weak so that you know. And part of that isn't just to be respectful and keep you involved, which is all good, but our brains can connect and be able to tell a muscle what to do a lot easier if we have a good idea in our head about where that muscle is. If you're trying to strengthen or squeeze something and you have no clue where it is, it's going to be very difficult for your brain and that muscle to make that connection again. We usually use initial visual, like I will first just observe the area and see what I see. Is there anything that looks, that I need to be aware of that way? And we do that before we would actually do the digital exam. And we're starting with external palpation, which is why I showed you the picture of those muscles that were superficial, because I can palpate those and check for them whether they contract and relax just by even external palpation. And then when we do the internal component of the assessment, it will proceed based on patient tolerance and the external assessment. Some people may not want to proceed just because they're a bit nervous, a little shy, feeling a bit vulnerable. Others are having severe or significant pelvic pain at the time of the exam and may not be able to tolerate a rectal exam. And if they cannot, we've usually identified that already, and we're already trying to think about other things that we need to do or address so that we can do that internal exam. And the internal exam is via the anus or the rectum, and several measures are taken to reduce the discomfort during that portion of the exam. It's really quite just common sense. And the physical therapist will palpate the muscles. We're trying to figure out which ones work, which ones aren't. We know by where we are palpating internally which muscles we're on, and we can specifically test each one to see where you need to focus your attention. And the physical therapist we're always giving you guys feedback. We're telling you, oh, this is tense, or this is nice and relaxed. This one is like grade 1 strength. This is grade 3. This is grade 5. Like, we're always telling you and communicating what we're finding so that you can follow along and then it makes sense why we're going to do what we're going to do later in the treatment. So what do we do when someone has tension? Because a lot of people don't talk about this. But you could have muscle tension in there. And if a muscle's doing a big cramp or if it's really tense, it can't contract properly. So we first have to figure out why. So it might be a problem with your back, hips, pelvic girdle, might be a problem with your guts. Maybe you're having diarrhea or constipation. Maybe it's psychosocial or psychological factors. Maybe you had a traumatic medical experience during the procedure. I've had men who ended up with severe pelvic floor muscle tension because their catheter wasn't properly inserted and they had pain with their catheter for a couple of days post-op, or they ended up with an infection. Like, there's a lot of things that can cause tension in the pelvic floor that will impair their ability to do a proper contraction. So we address the source, whatever it may be, and then we do muscle relaxation strategies to try to get those muscles so that they can turn on and off instead of being stuck on the on and just doing that well. And then and only then do we progress to strengthening. If someone has tension in their pelvic floor and we get them doing Kegel exercises or strengthening, we will worsen that tension for them, cause more pain and more pelvic floor dysfunction. So when someone has weakness, there's two main things that are going to do it. It could be some nerve damage. And if that happens, you have a loss of muscle contraction in the pelvic floor muscles that are necessary to maintain continence. And it won't respond. So if there's nerve damage, we can try as much as we want to get that muscle to work. But if the nerve is really not conducting properly, the muscle does not respond. It's like the head and the muscle are missing the connection. And it's very different than one that's just weak, because it'll contract. It'll just be weak, as opposed to where I'm saying, no, this muscle contract this muscle. and it doesn't respond at all. There usually is a loss in the connection between the two, and that's why they can't get the muscle to contract. And if that has happened, if it actually is nerve damage, there is no amount of strengthening a muscle that will make it come back because the connection is lost. In those cases of moderate to severe or lack of muscle strength, then often they will do the artificial urethral sphincter surgery to try to give you something else to clamp down on that urethra to maintain continence. If it's the muscle, the connection is still there. The nerve has not been damaged or not significantly. The muscle can still get the message and can still contract. Then on those ones, they'll just have a decreased ability to contract the pelvic floor muscles. And they will respond to verbal or tactile cueing, meaning if I'm tapping on the muscle, if I'm telling you to make it contract, even though it may be weak, you can actually make it happen. It just doesn't work great yet. And those ones definitely respond to physio. You just need to know what muscle to use, how to get it to start working, and practice like anything else that's weak to make it stronger. Those mild to moderate cases often improve with pelvic floor training. However, those that do not regain adequate control are still candidates for other medical interventions. The other medical interventions, which are definitely not my scope of practice, but I know that you guys, some of you will be already on the road on some of these, but it's anything from pharmacotherapy, so there's different things they can use, the bulking agents they can use at times, and the surgical options, which I'm far more familiar with if anybody's ended up with that. So in summary, the benefits of pelvic floor physical therapy is basically we're just trying to optimize that pelvic floor health and its functions. Pre-operatively, I love seeing people before they go to surgery so I can get their baseline. We can optimize everything, make sure those joints are moving good, make sure all the connective tissue is good. We can teach them how to do the strengthening pre-op. You may already be strong, but it's good to just practice the exercise so you already know how to do them so that post-op you basically hit the ground running, and it's easier to teach them when those muscles are not already dysfunctional, just like in other surgeries. Post-operatively, we know that we're going to assess the pelvic health again now that it's post-surgical, and we customize the treatment for the individual patient and their needs and what they need. So that we can optimize that recovery, whether it's in terms of urination and or continence, the strength, the tone, coordination, and erectile dysfunction. And it's an opportunity more than anything else for that open discussion, ask questions, helpful suggestions. Most pelvic floor physios, if we're in this job, basically nothing's off limits for discussion because most often we're the ones that spend quite a bit of time with these patients. And so we're the ones that we have time to talk and discuss some of these more things that maybe don't come out in the first 5 minutes of a conversation, but could come out at maybe 15 or 20 minutes. So that's basically all I have for the presentation. And if there's any questions, I would more than love to answer them or at least try to.